Dear colleagues, I want to share one case which is a really innovative approach of treating large macular holes. It is called autotransplantation of retinal graft in treating of large macular hole. Here is my team which made this possible, and I really thank them for that. The patient is female, 68 years of age. The right eye has undergone 3 operations for macular hole. The first one was phaco plus pars plana vitrectomy, IOM, peel and gas, but unfortunately the hole did not close. Then we go for a second surgery, 23 gauge with fluid air exchange and the drainage of the hole and heavy silicone Oxan HD tamponade for 3 months. The macular hole was closed. We then removed the silicone and the uncorrected distance visual acuity is 0.6. The other eye was the worst eye because the macular hole was over 600 microns and function was uncorrected 0.05. So the chances for closure was really low. Bear in mind the first eye, so we decided to take a new approach. So this is the OCT of the first eye after the 3 surgical interventions and everything is okay. This is the left eye which we will need to operate, and it is the hole is approximately 647 microns. We see detached, a little bit detached posterior hyaloid. We see thick ERM and we see cysts, a lot of cysts in the wounds of the macular hole. This is the Lombroso M-phase report. We can appreciate the retraction of EOM and the microcystoid edema around the hole and the large hole. So I just pinch the retina and my assistant gently injects a saline through 2 cc syringe. And now we'll see the detachment already created. You see the shadow of the detachment. Here it is. My next step will be by manual technique to create a flap or graft. I use curved 23 gauge scissor in order to create the opening. I don't need to do any type of diathermy or pre-laser the area because this is far periphery and the perfusion is really low and I don't expect to have bleeding. On the other hand, it is not ora serrata because I need to have at least 1 vessel over my graft in order to orient the graft position, the site of the photoreceptors, the outer retina or the inner retina. So I cut a square graft, at least 1 pupil diameter or maybe larger, and now with crocodile forceps gently I will grab the edge of that graft and will cut it free from our harvesting area. Now this is 23 gauge cannula, and I will try to put PFCO, but it's tricky. Anything which is free floating in posterior pole is really tricky to be placed somewhere. Now I switch the hands. Again I use crocodile forceps 23 gauge, and I try to stabilize the graft with more PFCO. Again, no luck. Now I will remove some of the PFCO. Again, we'll try to hold the graft in place. Now this is a 23 gauge fine tip spatula from Goider, which I will use to stabilize gently this graft over the macular hole, or at least I will try. Now I switched my hands and gently will press the graft over the macular area and will put the PFCO. Again, no luck. Honestly, this is the trickier part from all the surgery, to keep the graft on the desired space over the macula. Again, the spatula. All the time I try to maneuver it on the right position, and the only thing that guides me is the vessel which I have above the surface of the graft. Now again I will try to hold the graft over the macula and will try to stabilize it with PFCO. Maybe now I will get lucky. Yes, at last I have my graft over the macular area. Now with 23 gauge EOM forceps, I will adjust the placement of the graft over the macular hole. Gently, and now it is finally in the desired place. Now, the rest of the surgery will continue as regular retinal detachment surgery with large horseshoe tear. I will laser the area from which I have harvested the graft, and that spot was chosen because the tamponade will be effective compared to the lower parts of the retina. In the far periphery there is less blood perfusion, so no blood leakage would be expected, so I will avoid the diathermy and I will keep my graft perfused until the end of the harvesting. I will not have any PVR activity because the RPE in the periphery is less prominent under good tamponade for a PVR activity compared to the PVR activity on the posterior pole near the arcades. So 3 rows on green laser, then I will laser also the spots on which I had created holes with 41 gauge needle just for a precaution. Now this is the implantation of the silicone. This is our first post-op day OCT. We see that the flap is oriented with the right side and positioned above the retina. We have almost complete closure of the wounds of the macular hole. This is the unphased OCT, which shows our patch nice and well positioned above the hole, maybe a little bit on the side, but still plugging the hole. This is the Lombroso M-phase report, which shows again the position of the flap, the position of the hole under the flap on the right screen, and we have improved corrected near vision acuity. The function was 2100 or 0.2 with plus 8 diopter sphere. This is due to the silicone tamponade for near, and the Braille function was 2400, which is 0.05 with plus 3 diopter sphere. So we will continue to check this patient to see if the graft will move or migrate. We will look for ERM formation, and we will see how the function will improve or deteriorate. So we think that in large macular holes, these techniques could be feasible to be used.